All right, so left off talking about the menisci. I think I bored almost everyone to death on Friday. So the good news is today is going to be a little shorter. Kind of overestimated the amount of time it should take to cover the hip and the knee. This is day 4 of them. So we'll finish up the knee today. A lot of the muscles you're going to see are repeats from what we talked about with the hip. There are a lot of biarticular muscles that act on the knee. So maybe not a ton of writing for you today. So this will conclude, like I said, the hip and knee, and then the next time we'll move on to the fundamentals of the nervous system, so to completely shift gears. So, like I said, last time we left off talking about the menisci. Remember that those are fibrocartilaginous rings that sit atop the medial and lateral tibial plateaus. What are their two jobs? Since I don't have that up on the slide, what are the two primary things the menisci do? Yep. Good, joint stability and shock absorption. So remember that they increase the congruity between the tibia and the femur, and so they help stabilize the joint. They limit anterior posterior motion in particular, and then they help with shock absorption. So whenever you get compression between the femur and the tibia, as mentioned last time, based on the different directions of the fibers, there we go. Those fibers on the most superficial fibers will kind of press out. And so that then helps absorb some of that compressive stress. All right, so then on to the ligaments. So there are 4 primary ligaments of the knee. There are more. So if you're playing with the anatomy app, you'll find some other ligaments that I've hidden. But just to keep things as straightforward as possible, we're going to talk about the big 4, and we'll leave off some of like the meniscal ligaments and those kinds of things. So the big 4 ligaments of the knee, the first 2 are your cruciate ligaments. And so they're called cruciate because they make kind of an X inside of the knee if you view the knee from the medial or lateral aspects. So they're cruciate because they cross. They are entirely inside of the knee joint, so they are intracapsular ligaments, as opposed to the other 2 we're going to talk about. One of them is effectively a capsular ligament, and then one of them is purely extracapsular. So the ACL is the one you've probably heard of, the anterior cruciate ligament. In terms of what you're looking at here, so you're looking at a view kind of from the posterolateral view of the lower leg. Obviously, I've taken off the femur, and so you can see, so here's the medial aspect, and here's the medial meniscus, and then lateral aspect and lateral meniscus, and so your ACL is here. It's the green one, obviously. And so it runs from the posterolateral, so backside aspect of the femur, to the anteromedial aspect of the tibia. So it runs from high and in the back and on the outside to low and close to the midline. So comes across at an oblique angle inside of the knee. So in terms of motions resisted by the ACL, when you're talking about those, one thing to be really familiar with or be really careful about is, are we talking about a motion of the femur or a motion of the tibia? I'm always going to describe motion of the tibia. So the motions resisted by the ACL, and there are really 3 primaries. The first is called anterior translation, which means forward movement of the tibia relative to the femur. So basically, one of the ACL's main job is to keep your shin from sliding out from underneath your femur. So it prevents that anterior translation or forward movement. Another thing it prevents is called abduction of the tibia. And where do we see that? We see that with valgus forces. Remember, valgus forces are forces from the outside or from the lateral aspect that push toward the midline. So when somebody's knee buckles medially, that's a valgus force, and you abduct the tibia. So the ACL then limits abduction of the tibia. And then the last one is it actually resists both types of rotations. So it limits both internal and external rotation, primarily internal rotation. But it does also limit external. So primarily internal rotation of the tibia. So really the big 3 I'm looking for: anterior translation, so forward movement of the tibia, abduction of the tibia, and then internal rotation. But keep in mind that it also limits external. So how do you injure your ACL? What's the classic mechanism? Anybody know? Okay, it could be that. So contact mechanisms. So contact mechanisms account for about 20% of ACL sprains. So if you're thinking about, when I envision this, a lot of times I'm thinking about like a big offensive lineman in football is locked up blocking somebody and somebody falls on the outside of his leg. That would be a contact ACL sprain. That's a fairly common contact mechanism. Non-contact account for 80% of ACL sprains. So most of the time, nobody touches you, you just land wrong. And so usually it's One of the more classic mechanisms is somebody lands with their knee in extension and the foot kind of in plantar flexion. So you see that when somebody tries to stop and they stop wrong. Then the tibia is going to slide forward. That can stress the ACL. Another thing you're going to see is change of direction, where they're running full speed and they stop and plant and turn. So in doing that, you can see that I've just done 3 of the things that the ACL limits. If I stop really hard, what I'm going to do is get a big quad contraction, and your quads, the muscles on the front of your thigh, shift your tibia forward, so they cause that anterior translation. So that's going to put stress on the ACL. And then while I'm planted, I turn and change directions. Now I'm getting external rotation and abduction of the tibia. So those plant and change of directions are pretty classic non-contact injuries. So for example, I'm going to show you one from the Bucks from a few years ago, poor Jabari Parker, who could never stay healthy. So watch Jabari Parker here with the ball, and he's going to change directions, and then you'll see it from a couple different angles here in a second. But what you're looking for is you're really going to see that anterior translation and internal rotation when he stops to change directions. You see the knee buckle medially. Oops, too far. So watch his right knee, or left knee, sorry. So as he goes to change directions, right, so you get that internal rotation, that forward shift, and again, that valgus force there. So classic mechanism. So those are the things the ACL limits. Yeah, great point. So with the ACL, like oftentimes, if they don't, go to commercial break or whatever, if you watch the athletic trainers, if you watch the orthopedists on the field, they'll do a couple different tests. The main test they do is actually called the Lockman test. And so basically what you do is you slightly flex the knee to about 20 degrees. So you take one hand, hold up that thigh, take your other hand, put your thumb on the tibial tuberosity, and you just slide, see if you can slide their tibia forward. The other test is basically put their lower leg at 90 degrees. It's called an open drawer test, and you try to slide it out like a drawer. The tough part about the open drawer test, the more you flex their knee, their hamstrings are going to spasm. And so if their hamstrings are contracted, that's not going to let their tibia slide forward. And so you get a false negative where you start pulling on their knee and you're like, oh, it doesn't slide forward. That's because they're contracting their hamstrings. So the Lockman test is a little bit better because the hamstrings aren't in quite as good of a position. And there's several more, but those are kind of the big 2 that you'll see. So those are the ACL. And then the PCL, the posterior cruciate ligament. Oh, let me show you some other views. So there's one view of the ACL. There's from the anterior aspect. And so again, you can see how it kind of goes from high in the back to low in the front. And then more of a superior angle on that one. So you can see the ACL there as well. The PCL, on the other hand, so the posterior cruciate ligament, again, makes an X. It doesn't cross as far anterior to posterior as the ACL does. The ACL travels much farther, posterior to anterior, than the PCL does. So you can see the PCL highlighted there, and then there's a posterior view of the PCL. So it really limits one thing, which is posterior translation of the tibia. It keeps your tibia from sliding backwards. So it is pretty unusual to injure your PCL in a sporting context, at least from the standpoint of an isolated PCL injury. Most of the times you injure your PCL, you've hurt something else as well. So that could be PCL MCL tear, could be PCL ACL tear. It's a multi-ligament injury most of the time. If you don't have a multi-ligament injury, usually it's hyperflexion. So their foot is in plantar flexion, they're on the ground typically, like so they're on the knee. So it's like a football player, somebody that's kind of like on one knee and somebody hits them and forces their knee into hyperflexion. Sometimes it'll shove the tibia backwards a little bit, and that can cause PCL tear. The classic mechanism is actually not from sports. It's called a dashboard injury, which is if you're in the car, you get into a wreck, you slam into somebody, that tends to push your dashboard back into you, right? So it pushes it into your lower leg and can cause your tibia to shift backwards. So oftentimes the PCL is actually injured in auto accidents. So that's a classic mechanism there. Other things, the PCL test is actually one of the neater tests, I think, because it's super easy to do. If somebody's injured their PCL, basically all you have to do is lay down on their back, so piece of time, flex their knees to 90 degrees, and you look at the tibial tuberosity on either side. Their PCL is torn. That tibia is going to sag backwards. It's called a sag sign. And it's pretty obvious. You'll see kind of a U shape in their patellar tendon. So it's a pretty obvious injury when that happens. So PCL, when it's posterior translation of the tibia. Both of those ligaments, again, they're intracapsular. So if you get damage to either of them, especially the ACL, you tend to get really big swelling. ACL usually within 24 hours just balloons up big. Not in everybody, but in a lot of people. And so their knee, gets huge, and it's pretty obvious that they've torn their ACL. The other thing, one of the classic things with ACL injuries is they tell you their knee gave out. Now you can get that with some other injuries, like you can get that with one I'm going to show you here in a second, or talk about in a second. You can also get it with patellar issues, like if the patella isn't tracking correctly. Sometimes you can get some problems with that. But oftentimes, if you see somebody who changed direction, they immediately collapse, and they tell you they felt like their knee gave out, almost always an ACL. All right, so those are the cruciates. Those are the intracapsular ligaments. So let's go to one capsular and one extracapsular. So now you're looking at the medial aspect of the right knee. And so the ligament that's highlighted there, so I left the superficial layer of the joint capsule on there, so the fibrous layer is still on there. And that is your medial collateral ligament, more colloquially referred to, or more, I guess not colloquially, more anatomically correctly referred to as the tibial collateral ligament. It's on the tibial side of your knee. So your MCL, or your tibial collateral ligament, really resists two things. It resists the valgus force, so it keeps the knee from buckling medially, and that's the most common way that it's injured. So typically MCL injuries are contact injuries. So that football lineman I was talking about, somebody falling on the outside of your leg. That's a really common way for MCL injuries to occur. The other thing that resists other than valgus forces, and I'm using valgus force and tibial abduction synonymously, they mean the same for me right now. Because the valgus force produces the tibial abduction, probably more accurate. The other thing is external rotation of the tibia. So tibial abduction and tibial external rotation. So one of the things you might have noticed is that the ACL limits rotation, both internal and external, and also abduction of the tibia. The MCL limits abduction of the tibia and external rotation. So it is not uncommon to injure both your MCL and your ACL with a big knee injury. So if somebody really changes direction, or like I've seen it in a hockey player, his skate got caught, like he tried to change direction, he got caught kind of in a groove, and so it rotated his leg out. So really big valgus forces or really big rotational forces can sprain both the ACL and the MCL. It's not super uncommon. One of the things I did tell you about the MCL that is important is that it essentially has two sets of fibers. There's a superficial set that are almost extracapsular ligaments, and then there's a deeper set of fibers. And the deeper set actually connects to the medial meniscus. And why that matters is that helps hold the medial meniscus in place, but it also means that if we get a really big knee injury like I was talking about, then not only would you injure your MCL a lot of the time, but you also injure the medial meniscus. And so if you injure all three of those together, ACL, MCL, medial meniscus, one of the terms for that is the unhappy triad of knee injury. And so with really big knee injuries, it's not uncommon to have both of those. Same thing, with an ACL injury, it's also fairly common to have a medial meniscus injury, just because the medial meniscus tends to get pinched, like if you're stopping and changing direction, the medial meniscus tends to get pinched and twisted between the femur and the tibia, and you can tear your meniscus as well. And that was that bucket handle tear I showed you last time. Yep.
So how long would like a recovery be of an ACL, MCL, and meniscus?
That's probably, you're looking at a year. The MCL, we do a lot of rehab with that. If you can really strengthen up those pes and serine muscles and the hip adductors, that can help reinforce the MCL quite a bit. The ACL, you can return to play in as little as 7 months post ACL. But the faster you return to play, unless you're Adrian Peterson, but for everybody else, the faster you return to play, the more likely you are to have that injury again. So especially, we see that like in adolescence. So it's, like a high school football player, they come back in less than a year, they're much more likely to injure their ACL again. Because one of the things is usually with ACL tears, it's this, they have bad mechanics, oftentimes anyway. Sometimes it's just an unfortunate accident, but oftentimes they kind of have bad running mechanics. So, if you see somebody where they land from a jump and their knees buckle medially and they tear their ACL, we got to fix that knee buckling before we let them return to play. If we don't, if we're just like, well, they're pain-free and they can run and they can change directions without it giving out, go ahead and go back and play, it's probably going to happen again. And so that's one of the things you do see, especially with the rehab of adolescent athletes, is it's like, well, we solved the problem. You can run, you can change directions, get after it, but we really haven't solved the underlying problem of they've got pretty crappy running form. We need to really strengthen up the hip and foot musculature, and so we just throw them back out there and it happens again.
Like if you tear your MCL, you can still
Yeah.
Can I see you and then like get surgery after?
Yep, you can. Yeah. So especially with like a grade 1 MCL sprain, you know, it hurts, especially if you apply that valgus force to it. But you know, a week or two, lots of knee extension exercises, some hamstring stuff, and usually they can return to play fairly quickly. It's still not as stable as it was before, but it's good enough to play on.
Maybe just put like one of those injuries, like the metal on the outside.
Yep. Yeah, one of the things about braces is really what they do is limit the severity of an injury. So you're still going to sprain your MCL or your ACL, but rather than being a grade 2, it's a grade 1. So you don't really tear fibers, but you stretch fibers. So that's one of the things that braces are good for, is limiting the severity. So that's your MCL. Again, tibial abduction, external rotation, and then your LCL, which is also known as your fibular collateral ligament. From the lateral aspect of the knee, it is purely extracapsular. So it doesn't have any fibers that connect to the knee capsule. And so it's the one of them. You can find your MCL. It takes a little bit of practice, but it's not too hard to find. Your LCL is super easy to find. If you cross one leg over the other on the outside of your knee, you'll feel a little ligament that runs straight up and down from the head of your fibula. It tends to be pretty obvious because it's, again, outside of the capsule, so it pops right out. So the LCL limits two things. Tibial adduction, so it keeps your tibia from moving toward the midline. And the force that causes that is called a varus force, V-A-R-U-S, varus force. So it prevents tibial abduction and prevents tibial internal rotation. So the opposites of the MCL. So adduction, internal rotation.
So a varus force would be like if someone hit like the inside of your knee and like push outward.
Yeah. So the most common varus force, like LCL injuries are fairly common skiing injuries. Like if somebody tries to stop and they get their skis kind of crossed up and then their knees buckle out, that's one of the more common mechanisms for those kinds of things. I've seen some on football players, but usually it's kind of like legs getting tangled up. There's not like, you know, it's pretty rare because you're not usually exposed like that where somebody's got to come in from the inside. So it's usually kind of legs get tangled up and they fall weird. All right, so that's the LCL or fibular collateral ligament. All right, so actions of the tibiofemoral or the knee joint. So the knee joint, primary joint of the knee is a hinge, and so that's the tibiofemoral joint. So at the hinge joint of the knee, there are four motions. So there are flexion, extension. So flexing your knee is bending it, obviously. Extending your knee is straightening it. And then internal rotation is taking the front of your tibia, rotating it toward the midline. External rotation, take the front of your tibia, rotate it away from the midline. So we can do those four things there. Flexion, extension, a little bit of internal rotation, a little bit of external rotation. Not a ton, but you get a little bit of both. The other joints of the knee, one of them is the patellofemoral joint. And so at that joint, you get the interaction of the articular surface of the patella with that intercondylar groove, so the groove between the medial and lateral femoral condyles. So the patellofemoral joint is another joint in the knee complex. And then the other joint in the knee complex is the proximal tibiofibular joint. Now, neither of those are up there. We'll talk about the patellofemoral joint in a minute, but the proximal tibiofibular joint describes the interaction between the head of the fibula and then the proximal aspect, or the let's go with that proximal aspect of the tibia. Ideally, that's an immovable joint, so that one should never come up. All right. So let's do muscles. This one's a repeat, so you already have this in your notes somewhere, hopefully. So the first muscle for the knee, rectus femoris. So remember that rectus femoris originates at the anterior inferior iliac spine, the AIIS. It's that one of the quadricep group that is right in the middle. It's the one that makes the V shape in the middle of your quads. And then all of the quadricep group, obviously there are four of them, all of them come together. They insert via the patellar tendon, or the anatomy app calls it the quadriceps tendon. I'll call it the patellar tendon on the quiz, so just so you're ready for that. Patellar tendon and quadriceps tendon are the same thing. So it inserts via the patellar tendon into the tibial tuberosity. So remember the tibial tuberosity is that big obvious knob there along your midline on your shin. And of course your shin bone is your tibia. So rectus femoris at the hip is a hip flexor. So it's a flexor acetabular-femoral. And then it's an extensor, tibiofemoral. It's an extensor at the knee. Yep.
Do you ever abbreviate TI?
I do, yeah, so later in the slide I'll do. I think I tried to write it out this time because I was like, oh, it's the first time I used it. But yeah, it'll show up as TF. All right, oh, there's it. The rest of the quad group. So the rest of them are vastus something. So the first one's vastus medialis. The vastus medialis originates on the medial lip of the linea aspera. So remember, the linea aspera is the rough line on the back of your femur. So it originates on the medial aspect of that, medial to that adductor group, where they insert. And then it inserts again via the patellar tendon into the tibial tuberosity. And it is only a knee extensor, so its action is only extension TF. So vastus medialis is the one that makes kind of the teardrop shape on the inside of your knee. That's your vastus medialis. You notice it if you've ever ridden the exercise bike. It's a good vastus medialis burn a lot of the time. Squatting also brings out irritation of that one. Yep.
Isn't that the one that's like mainly involved when you do both squats, like when you do like right next to each other?
Yeah, so that's kind of the thought there, is that that kind of close squatting stance emphasizes medialis a little bit more. I don't know. I haven't seen any EMG studies on that. So I don't know if that's accurate. I do know, because in thinking about this, the way that I learned this originally was, well, if you do, I think they call them dancer squats. So it's like one of the things you should work on is dancer squats, where you're like out here kind of sumo stance, and then you just go down a little bit and come back up. But those are really good for the vastus medialis, and those really don't develop lateralis. And EMG studies didn't bear that out. They're both pretty equally active in that motion. So I don't know if that's bodybuilding lore or if that's correct.
That's just what I've heard. Like you can be right next to each other and kind of like put your knees out and like go all the way down.
Yeah.
Like, a lot of people do it on the half squat.
Yep.
They basically touch their butt to like the back of their feet.
Yep.
And that's supposed to. I don't know what that actually does.
Yeah. I don't know. Yeah, I'll have to look at that, see if I can find some EMG studies on the different quad muscles. Yeah, so medialis is the teardrop shaped one. Then we got lateralis on the lateral aspect. Lateralis is super obvious. It takes up all of the outside of your thigh. So because it is a big muscle, big origin, so part of it originates on the greater trochanter, part of it originates near the gluteal tuberosity, which hopefully you remember is where the inferior fibers, I have to think about that for a second, the inferior fibers of glute max insert there, the gluteal tuberosity. Vastus lateralis originates near there, and then the rest of it originates along the linea aspera. So medialis along the medial aspect of the linea aspera, lateralis on the lateral aspect, and then again inserts into the quad tendon. And then just highlight it by itself. So you can see it sits underneath the IT band, because the IT band is on that drawing as well. So it's only an extensor, tibiofemoral, so only an extensor at the knee. And then the last quad muscle is the deep one. So these first three were superficial, and then we got to take off rectus femoris to get to the last one. So the last one is vastus intermedius, takes up most of the anterior and lateral surface of the femur, and then runs into the quad tendon or the patellar tendon, inserts in the tibial tuberosity. So there's it. But again, to get to it, had to take off rectus femoris. So it sits right in the middle, just underneath rectus femoris, the deep muscle. And so it is also only an extensor at the tibiofemoral joint. So your quad group then, rectus femoris, vastus medialis, vastus lateralis, and vastus intermedius. So just remember that rectus femoris is the only one of the four that doesn't have vastus in the name, and it's also the only one of the four that crosses both the hip and the knee. All right, so I got a case study for you, which is that, so I'll just give you the bare bones. We'll pretend you're a physical therapist, athletic trainer, doctor, whatever you want to be. And a 22-year-old woman comes to you in the clinic or the athletic training room, and she is complaining of anterior knee pain. She comes in, says the front of my knee hurts. What else do we want to know?
What kind of pain?
Great question. Kind of an aching or stabbing pain.
How old did you say she was?
22. Been hurting for about 4 to 6 weeks and getting progressively worse. Really good question so far. Yep.
What kind of daily activities do you do?
Good. She's a recreational runner. So she's been running about 20 miles a week, although it's had to decrease because of this knee pain. She just hasn't been able to keep up that running volume. And she notices when she runs that hills are particularly problematic, especially downhill. So her knees hurt a lot worse running downhill than they do hurting going uphill. And then flat ground is painful, but not near as bad. So downhills are particularly problematic. She wears shoes that are, we'll go with pretty neutral, like some Nike Frees or something like that. So they don't really control foot motion. Throw another factor in there. Not very good foot control in her shoes. Anything else? Hurts getting into or out of cars, so especially sports cars. So the lower the car, the less comfortable it is, right? Sometimes sitting down or standing up hurts. Again, anterior aspect of the knee. She can't really pinpoint where it is. It's kind of just like everything on the front of my knee hurts. Occasionally it swells, but it's not a really obvious swelling. So with this particular condition she's got, it's not going to be like, oh man, your knee is swollen. It's like, that might look a little different. I don't know. It's hard to tell. So it is pretty subtle swelling that she's going to get here. What else? Going downstairs hurts. Sometimes going upstairs hurts. And then occasionally, especially when it's good and fired up, like when her knee is really hurting, it feels like her leg gets out. Any guesses as to what could be going on? Yep, really good. Could be patellar tendonitis. Same basic mechanism here. Yep. So what I was describing to you is kind of this general patellofemoral pain syndrome. So basically the gist of it is her patella is not sliding in that intercondylar groove like it should. And most probably it is sliding laterally. So basically the patella is kind of dragging against that lateral femoral condyle. And so when it does, when it starts to drag there, that is going to damage the cartilage underlying the patella, but also then the cartilage on the lateral aspect of the femur. And so then that starts this inflammatory process, that causes the swelling, and then those things cause pain. So why is her patella not tracking correctly? Why is it sitting laterally or moving laterally in that groove? Go ahead. Yep, so she does have that. So weaker abductors. One of the reasons I mentioned this with a quad group is because the way that I learned this a long time ago in athletic training programs, one of the thoughts, 15 years ago, was that there was an imbalance between the quad muscles. The vastus lateralis was too strong relative to medialis, so because lateralis is too strong, it's pulling the patella laterally. Probably not the case. What is probably going on, and one of the things with patellofemoral pain syndrome, it's tough to tell what the real causing factor is. There's a number of different things that they could play into. One is patellar position. So somebody who's not here today, but asked me on Thursday of last week, asked about their patella, and they basically said, well, my patella is I have a really long patellar tendon. And so that particular, I'll say deformity, is called patella alta, which means your patella is too high. And so when your patella sits too high, that lengthens out your patellar tendon, makes you more likely to get patellar tendonitis, but it also changes where the patella sits relative to the femur. So it can make it more likely that it's going to drag across the femur whenever you move from extension to flexion. Other things could be the shape of your femur. They could have a shallow groove. They could have an especially steep groove on the lateral aspect of it. So that could be causing the drag. A more likely cause would be, it's called femoral anteversion. And so basically, if you've got the femoral neck and then, femoral head, femoral neck, and then greater trochanter, anteversion just means that your greater trochanter is too far forward. And so if your greater trochanter is too far forward, so you have a weird angulation in the neck of your femur, that's going to cause what's referred to sometimes as being pigeon-toed, where you bring your toes together. So that could be from that anterior angulation of the femoral neck. And so if you're in that position, sort of that pigeon-toed posture, that's obviously then going to lengthen your IT band, right? And so it'll cause it to maybe click across your greater trochanters. It's going to tighten out here. One of the things I should mention with this, so you're looking at kind of a 3/4 lateral view of the knee. So this is vastus lateralis here. This is your IT band. And then one of the things that's actually missing from this is you have this band of fascia or connective tissue that runs kind of from the IT band and kind of across the lateralis muscle. You have a similar thing on the medial aspect. And so if you get tightness of the IT band, or TFL or glute max. If the IT band is pulling, then that's going to pull on this fascia that is connected to the patella. And so then that's going to cause the patella to track laterally. So anything that's going to cause tightness in the IT band or potentially the IT band, if it's like internal rotation at the hip, that could lead to that. Tight musculature, so tight quads will pull the patella against the femur. Hamstring and gastroc tightness basically causes the same thing. Hamstring and gastroc are both knee flexors. So if either or both are tight, you can't get full knee extensions. They tend to kind of land with their knee flexed. That really pushes the patella up against the knee or up against the femur. IT band tightness, as I mentioned. Overpronation, we'll talk about that a lot more. We have a whole lecture on gait, but overpronation, basically what that deals with is that during normal walking or running, your foot, you have a pretty obvious arch in your foot, most of us do, your medial longitudinal arch, and as you step on your foot, that flattens out. And then as you push yourself into the next step, that returns. It kind of springs you into the next step. Overpronation is basically your foot flattens out too much and stays flat too long. It basically stays in weight absorption mode too much. And so your foot flattens out too much, knee tends to buckle medially, tends to pull on the IT band and that lateral retinaculum. And so then that can cause pain. So it could be a foot issue. And then as we identified, weakness of the abductors. Yep. Mm-hmm. Yeah, so one of the things that tends to or that can help with that is orthotics. And so usually, like if it's, you know, a scenario, you know, in the athletic training room, one of the things you might try is like taping their arches and like, okay, did that make it better? Yeah, okay, then we'll send you to actually get an evaluation and get good orthotics. Because good orthotics can be pretty expensive. If you don't want to do that, it's not going to help. So you can kind of do, sometimes you can do off the shelf one, but usually try taping first. And if it helps, then we can buy the expensive one. Yeah, so a bunch of different stuff could cause it. But basically, either foot's too flat, got weak hip abductors, tight quads, a number of different things. But essentially it's causing the patella to drag. So we kind of take this shotgun approach oftentimes in treating patellofemoral pain syndrome. More common in women than men. Why is that? Women tend to have wider pelvises. So women tend to have wider pelvises, and so that changes the angulation between the femur and the tibia. It's called the Q angle. So women tend to be a little bit more knock-kneed than men because of that wider pelvis. So with that steeper angulation, tend to have more tightness laterally, and so it makes that patella more likely to pull laterally. So not to say that men can't have it, but it is more common in women than men. All right. Another muscle you've seen before, the Sartorius. So Sartorius originates at the anterior superior iliac spine, the ASIS. Inserts at the pes anserine, which again is medial to the tibial tuberosity, kind of this medial area of the tibia. So remember, Sartorius does a bunch of things. You can get 4 of its 5 actions, as I mentioned previously, if you cross one leg over the other. And when you do that, you'll do all the actions of the hip. So hip flexion, external rotation, abduction, and then knee flexion when you cross your leg over. The only one you probably didn't do is internal rotation of the knee. So that's its last thing. So it does 5 different things. It's not really strong in any of them, but it does do 5 different things. Sartorius often doesn't often cause problems. There's a bursa near it that sometimes can get inflamed, but in general, Sartorius not clinically involved. And then the next one's Gracilis, which is another muscle you've seen before. So there's Sartorius again, longest muscle in the body, with all the rest of them. Gracilis is the most medial of your adductor muscles. It doesn't have adductor in the name, but it is primarily an adductor. So as you can see, that originates from the inferior pubic ramus and close to the pubic symphysis. Also inserts the pes anserine. And so, again, primarily an adductor, and it is a flexor and internal rotator at the knee. Some books, apparently not the anatomy app, but some books have Gracilis as a flexor as well. But we're gonna just stick with the adduction. So adduction at the hip, flexion, tibiofemoral, internal rotation, tibiofemoral. So all your muscles that insert at the pes anserine, which include Sartorius, Gracilis, semitendinosus, are flexors and internal rotators. All right, now we got a hamstring group. Again, all these are repeaters. So you got semimembranosus, semitendinosus, biceps femoris. Remember that the hamstring group, all 3 of them originate at the ischial tuberosity. The short head of biceps femoris originates along the linea aspera. In terms of the insertions, semimembranosus, that posterior medial aspect of the tibia, or the way they wrote it there, or the way I wrote it there, but the posterior medial aspect of the tibia, all of them are extensors at the hip, all of them are flexors at the knee, or TF. The medial two, semimembranosus, semitendinosus, are internal rotators. The lateral one, biceps femoris, is an external rotator. So there's semimembranosus. Remember that it's deep to tendinosus. So there's membranosus underneath tendinosus there. There's tendinosus. Again, inserts at the pes anserine. So hopefully you have this from the hip top. Inserts the pes anserine, flexor, internal rotator. And then there's it with all of the rest of the muscles. So again, it's superficial to semimembranosus. Really obvious tendon. And then the lateral one is biceps femoris. Talked about the short versus the long head. It inserts into the head of the fibula. Again, hip extension or AF extension, flexion TF, external rotation TF. Hamstring group are all knee flexors. And then medial or lateral rotators. Then there's three more muscles that you haven't seen before. First of which is gastrocnemius. So gastroc is your big superficial calf muscle. It's the one that makes the W shape if somebody has a well-defined calf muscle. So it has two heads, that's why it has the W shape. There's a medial head and a lateral head. Each arises from the medial and lateral condyles of the femur, respectively, kind of just above each of the condyles, so just outside of the capsule. Two heads run together. They insert via the calcaneal tendon or the Achilles tendon. The two mean the same thing, and I will probably say Achilles. I will say Achilles most of the time, but just know Achilles tendon and calcaneal tendon, same thing. Insert via the Achilles or calcaneal tendon into the dorsal aspect, so the back of the calcaneus. Calcaneus is your heel bone. So inserts into your heel bone. So at the knee, gastroc is a flexor, so it's a tibiofemoral flexor, and it is also a really powerful plantar flexor. And so plantar flexion is when you come up on your tippy toes, or when you do calf raises, that is plantar flexion. Gastroc is a powerful plantar flexor. Primarily, it has a lot more type 2 fibers than another muscle that we'll talk about with the ankle, the soleus, which is deep to it. So it is less of a postural muscle than soleus is. One of the things with gastroc, if you've ever done leg curls, if you want to make it more of a hamstring specific exercise, if you're doing leg curls, plantar flex your ankle, so point your toes when you're doing leg curls. The easiest way to do it is like have your ankle in a neutral position on the way up on leg curls, and then plantar flex on the way down, because that takes gastroc out of it. So if you're plantar flexed, gastroc is acting as the plantar flexor, so that puts it at not as good of a position to be a knee flexor, and so it puts more stress on the hamstring. Bodybuilding tip of the day. Popliteus. So Popliteus is a knee flexor, but it is primarily an internal rotator of the knee. So you see the origin there. So the lateral condyle of the femur, so just above the condyle, and then that posterior medial surface of the tibia. So Popliteus, knee flexor, and then internal rotator. So really what Popliteus does, and we didn't get into the arthrokinematics of the knee much, but to reach terminal knee extension, which means to fully straighten your leg, that last, give or take 20 degrees of knee extension, you actually have to get a little bit of external rotation of the knee, and the ACL actually guides that. And so in order to flex your knee, the first thing you do is actually internally rotate it. So that unlocks the knee. And so Popliteus' job is to do that initial internal rotation to unlock your knee. So it's primarily an internal rotator, but it is also a flexor. And then the last one is Plantaris. So Plantaris originates above the lateral condyle, that supracondylar line, and then its tendon runs in with gastroc and soleus. So it actually runs into the Achilles or the calcaneal tendon, and then with that tendon, it inserts into the dorsal aspect of the back of the calcaneus. And so it is a knee flexor. Pretty weak one, because you can see its tiny little belly. It doesn't do much. So it's not, in terms of saying it has a tiny belly, there's not a lot of actin and myosin there, right? There's not a lot of cross-sectional area, so it's a weak muscle. So it is a knee flexor and plantar flexor, pretty weak at both. And we'll talk about it more with the ankle. And then that's it. So those are the knee muscles. So again, not too many new ones. So yeah, so the way the upcoming days look, or weeks look, so we're going to start basics or fundamentals of the nervous system. We're going to do that Wednesday, Friday. We'll start the brain next Monday. We'll finish that on Wednesday. Next Thursday is the lab quiz over the hip and knee. So you got a little more than a week to work with all of this stuff to get ready for that. So, and we'll meet for lab on Thursday for anybody that wants to come, and we'll go, we can go over all the landmarks and all the muscles and all that stuff. Yep, Gavin? Nope, it's just hip and knee stuff. So yeah, just today and the previous 3 days. Today and last week. Yep, good question. Anything else? Nope, awesome. All right.